What I'll do in the next half hour or so between now and the break is talk a little bit about cardiogenic shock and mechanical complications. The reason why we chose to talk about this topic is that in the setting of the exam, between cardiogenic shock and mechanical complications, there are certainly 3 or 4 questions every year, and so it's good to get an idea of what we're dealing with. So we'll start with a question. What is the most common cause of cardiogenic shock in a patient with a big ST elevation myocardial infarction? Is it a ventricular septal rupture? Is it a papillary muscle rupture? Is it just a large left ventricular dysfunction from the infarction, rupture of the ventricular free wall, or an aortic dissection? So most of you thought it was because of extensive left ventricular dysfunction, and that's the correct answer. So when you have cardiogenic shock in the setting of an acute myocardial infarction, there can be a number of entities that may be contributing to the patient's shock. And so clearly, the management of cardiogenic shock depends on the etiology of what's causing the shock. And so in the exam, you're going to get patients in shock. You have to figure out why they're in shock, and your ability to figure that out is going to lead you to the right answer. So the commonest cause of shock is nearly always left ventricular failure. What I mean by that is you either have a patient who's had multiple prior infarctions, and now they have a new infarction that's lowering their contractile reserve significantly, or more likely someone who's had a very large, extensive infarction that's causing a sudden precipitous drop in stroke volume and cardiac output. Other causes of cardiogenic shock, which will often come in the boards, will be folks who come in shock because of right ventricular failure. So these will be a group of folks who present with clear lungs, elevated JVD, hypotension, perhaps bradycardia in the setting of an inferior wall myocardial infarction. And that will be important to recognize because the treatment for this, apart from opening up the infarct artery, may be volume resuscitation. There will certainly be folks who present with ventricular septal rupture, where the treatment is going to be prompt emergent surgery. Others may have severe mitral regurgitation because of papillary muscle rupture. Again, they need prompt surgery. Free wall rupture, which is rupture of the ventricle, prompt surgery. So really important to recognize each one of these. And finally, there is another group. And the reason for that is there is a lot of shock that's iatrogenic. So where they want you to recognize that would be in a patient who comes in with a large infarction, who's got a lot of IV beta blockade, or who's got a lot of hypertensive medicines that have made them hypotensive, or in the setting of acute blood loss. So many of these patients have gone to the cath lab. They're prone to have a bleeding event, perhaps in the retroperitoneal space, so that you can't see that visually. And so when you take a look at this, folks, just see which of these categories they fit into, and that'll lead you to the right answer. So the question you want to see when you get this story in the exam is the extent of myocardial damage that you see on the EKG or what is described proportional to how sick the patient is? If it's a large anterior wall myocardial infarction on the EKG, patients in shock, you know the two are necessarily connected. But if you see a small inferior wall MI or you see a small lateral wall MI and the patient looks just much sicker than you would expect, then look for these other causes, and that's the clue that you'll get from the story up front. So which of the following findings is most consistent with the diagnosis of cardiogenic shock? Is it hypotension, tachycardia, tachypnea, evidence of ineffective tissue perfusion? So most folks got the right answer, evidence of ineffective tissue perfusion. Clearly, shock is when the cardiac output is not proportionate to the body demands, okay? So you can get hypotension as an arbitrary number in a whole lot of conditions. In fact, if someone has an ejection fraction of 15-20%, they may well come to their clinic and your baseline blood pressure can be 85, 90 millimeters of mercury. And the next thing you do is, if you treat that aggressively, you'll cause iatrogenic damage. So blood pressure by itself does not meet criteria for cardiogenic shock. Tachycardia, again, certainly is a component of cardiogenic shock, because when someone has shock, they have a small stroke volume. Cardiac output is stroke volume times heart rate. So clearly the heart rate is a normal compensatory response to a large myocardial infarction. But you can get tachycardia for a number of reasons. Take, for example, thyrotoxicosis. And so tachycardia by itself is not a part of the shock diagnosis. Ultimately, shock is the cardiac output is not meeting end organ perfusion. So the patient's not mentating, urine output is falling, there's some sort of end organ hypoperfusion that's taking place. So when we take a look at why folks go into cardiogenic shock in the setting of a large left ventricular infarction, this is the kind of figure that you'll see in most textbooks. So when a person comes in with a large MI, they suddenly have a large infarction and their cardiac output decreases because their stroke volume decreases. As their stroke volume decreases, it causes decreased systemic perfusion. That results in compensatory vasoconstriction as a compensation. The decreased stroke volume causes hypotension. Hypotension causes decreased coronary perfusion and continues to increase ischemia. Most of these folks have multi-vessel coronary disease, so they have ischemia both in the infarct and non-infarct zones. So ischemia begets ischemia, and the patient ultimately goes into circulatory collapse and passes away. So knowing that background, which of the following set of findings are most consistent with patients in predominant LV cardiogenic shock? You put a swan in and you get these 4 findings, and which one is which? Cardiac index of 3.2, a wedge of 18, an SVR of 1400, and a left ventricular ejection fraction of 58%. A cardiac index of 2, a pulmonary capillary wedge of about 25, an SVR of 1350, and an ejection fraction of about 33%. A cardiac index of 1.6 with a wedge of 12 and an SVR of 1600, preserved ejection fraction. And the last one, a cardiac index of 2, a wedge of 27, SVR of 2000, and an LVEF of 25%. Okay, so most folks got this wrong. And it's not, the reason was I set you up for this by showing that classic figure that I had up front. So the expectation for all of us is someone has cardiogenic shock, they have a decreased cardiac index, they have an elevated wedge pressure, and they have compensatory vasoconstriction. So this is what we would have expected in all the textbooks in the last 4 or 5 years. Just running the other things by, you can take a look at this guy. This guy is your classic right ventricular infarction. And then your choice was, this person is clearly not in shock. So your choice was between 2 and 4. And based on my figure, you picked 4, which was reasonably appropriate for the data that I presented you and what the conventional expectation is for most people who don't work in a coronary care unit. So these are right heart cath findings for patients in cardiogenic shock from the shock registry. 900 patients with cardiogenic shock, all in the setting of a large myocardial infarction. And you can see these are people in dark blue who have cardiogenic shock. These people, we wrote this up in the setting of a group of people who were not hypotensive. But take a look at the folks in dark blue. Their wedge pressure is elevated. They have an EF of about 35% in the setting of their acute infarction. They have a low cardiac index, and their SVR, unlike what you would expect, is near normal, only about 1400. So this feeling that we had, this classical doctrine that SVR is elevated in the setting of cardiogenic shock, is erroneous. And so when you take a look at the same textbooks, the newer editions, you will now see a separate arm coming out. And what we've noted is that when folks have a large myocardial infarction, they behave very much like folks who are septic. They have a large infarct, there are a lot of cytokines released, there's a lot of nitric oxide release, and because of that, there's a lot of vasodilatation. And so, despite them being in cardiogenic shock, most people with cardiogenic shock have a normal SVR. And so, if you come to a large unit like ours where we see really sick people, it's not unusual for the house staff to always think people are septic when they first come in with a large myocardial infarction. The bottom line is the end stage picture is very similar. And so this might be a potential question because this concept of SVR being normal in the setting of cardiogenic shock is now no longer new. It's about 5 to 7 years old. And as you go back to your units and see sick people, you'll gradually come to realize how true this is in the real world. So which of the following statements about revascularization in the setting of cardiogenic shock complicating myocardial infarction is untrue? And I use the word untrue just because we get more options here in terms of getting points across. So the benefits of revascularization for someone in cardiogenic shock is similar to the benefits for bypass surgery for critical left main disease. Folks who have cardiogenic shock and survive have NYHA class 1-2 at 12 months, which means they're perfectly normal folks and have nice quality of life at the end of a year if they were to survive it. Although there is short-term mortality benefit from revascularization, there is no evidence of long-term benefit by revascularizing these patients. And revascularization in the setting of cardiogenic shock is a class 1 indication. So which of these is untrue? 3 of these statements are true. So you have a split. Most folks picked C, that although there's short-term benefit, there is no evidence of long-term mortality benefit, which is the wrong answer. Let's move on. Let's do both these questions and we'll come back to the whole concept again. So let's go with this one. Which of the following statements about revascularization, again, in the setting of cardiogenic shock is untrue? The mortality benefit for an intra-aortic balloon pump in this setting is proven. The window for benefit with revascularization extends beyond that traditional 12-hour reperfusion window that we spoke about. The benefit with revascularization is seen both for patients who present and are transferred, and there's a decrease with mortality with shock over time. Good. Everybody saw, you can respond to the answer, that's a good sign too. You've got to be sensitive of your environment. So if you see the answer and you know the answer is right, you need to tick it. So that's good. Okay. So let's go with why we have this data. Okay. Most of this data comes from the SHOCK trial, which was a randomized trial published in the late 1990s, and it was the first trial in the setting of cardiogenic shock. It was designed at a time when most of these folks we did not take to the cath lab because we were almost certain they would die. So it was an 80% mortality with medical treatment in the setting of cardiogenic shock. And the first thing you notice was they were taken not in the conventional time window. They were taken well beyond the conventional time window of 12 hours. If they had shock, they were randomized into 2 arms. One arm got an intra-aortic balloon pump, and they got emergent angiography, PTCA, and CABG. The other arm got just medical stabilization. In this trial, at the end of 30 days, when you take a look at the number of absolute lives saved, there were 11 lives saved compared to not doing anything at all and medical observation. And this number increased to 13 per 100 lives saved for every 100 patients treated at 1 year, statistically significant. So when you employ an early revascularization strategy in patients with cardiogenic shock, you save 13 lives per 100 treated, which is exactly the number of lives you save for bypass surgery with critical left main disease in the 1970s when medical treatment was not even aspirin. So there's a significant treatment benefit. The only other thing that comes even close, which won't come on the boards this time around, but it will be there in 2 years' time, is transfemoral aortic valve replacement. So in the recent partner trial, for patients who had severe aortic stenosis who were ineligible for surgery, the mortality rate was reduced by 20% at 1 year by putting a percutaneous transfemoral aortic valve replacement. And so that's too new to come on the boards, but it's certainly going to come as an option for the same question that you do palliative aortic valvuloplasty on now. In the future, there is going to be a choice of going for a transfemoral aortic valve replacement. You can see that whether you were early after the infarction or late after the infarction did not seem to make any difference in terms of your benefit with revascularization. And whether you presented to the hospital or were transferred to an institution like ours also did not seem to be of any benefit. So the bottom line is, if you see somebody that you think is in shock in the exam, make sure you transfer that patient to a quaternary or tertiary institution that has the ability to do bypass surgery and intervention. More importantly, when you see what happens to these people over the course of a year, you can take a look at survivors of cardiogenic shock, and when you take a look at them after 1 year, you can see that most survivors of cardiogenic shock are in New York Class 1 or Class 2. So the fact that they're in shock today does not mean that there'll be cardiac cripples in the future. And so the early revascularization strategy provides them, if they were to survive it, gives them a quality of life that's quite meaningful. And finally, what most of the audience talked about was long-term survival, and that there was no long-term survival data. You thought the benefits were early, but would not be sustained. And so this is data from the shock trial out to 10 years on this slide. You can see the benefits of the early revascularization strategy compared to medical stabilization appear early, but the curves remain parallel and the benefits are sustained for the next decade. So the mortality benefit from an early revascularization strategy is over a long period of time and is not short-term. So just because of the impact of that trial, there is no doubt that in the exam you will have a number of patients, especially aged less than 75, who will be in shock, where the questionnaire the idea is to persuade you to refer them to higher centers to get further care because they can be salvaged in that situation. And then finally, we talked about the decline in cardiogenic shock mortality over the years, and you can see that in light blue, the mortality rate has significantly decreased over time from about 60% back in 1995 to about 40% here in 2004. It's still in that 35-40% ballpark. The mortality benefit is mainly for those who are younger. If you're old and you present with cardiogenic shock, the mortality rate is very similar to what the placebo mortality rate was back in the 1980s. This benefit is entirely attributed to performing primary PCI. Okay, so what do you do for folks with intra-aortic cardiogenic shock? These are the class 1 indications in the setting of cardiogenic shock. You put an intra-aortic balloon pump in these patients. Okay, the intra-aortic balloon pump is not associated with mortality benefit. It's just a supportive device. It's not a therapeutic device, which is why that was there in the question. You do intra-arterial monitoring. You perform an early revascularization strategy. You should put a pulmonary artery catheter in these patients. This is unlike the traditional shock data that you see in most critical care programs, where there is an increased mortality associated with the use of a pulmonary artery catheter in the setting of cardiogenic shock. So which of the following statements, again, is inaccurate? The mortality benefit with fibrinolytic therapy over placebo for ST elevation MI begins at 24 hours and extends out to 10 years. The incidence of rupture has decreased in the reperfusion era. Cardiac rupture is a surgical emergency and warrants emergent cardiothoracic evaluation. Lack of collateral blood supply is a risk factor for rupture. And I use these questions more to get points across than anything else. So most folks got the right answer, that the mortality benefit with fibrinolytic therapy over placebo begins at 24 hours and extends out to 10 years. It's a wrong statement. So the mortality benefit with fibrinolytic therapy certainly lasts up to 10 years. There's no doubt about that. We have multiple trials with thousands of patients showing that. However, if you take a look at fibrinolytic therapy at 24 hours, so let's say you did a clinical trial which was fibrinolytic therapy versus placebo, and you counted bodies at 24 hours, there'd be more people who were dead in the fibrinolytic arm. We call that the early hazard of fibrinolytic therapy because there's more rupture early on with fibrinolytic therapy. But then long term, the mortality benefit shows up. And so this is a wrong statement. Rupture has clearly decreased in the reperfusion era because as the more you open up the artery, the less likely you're going to have the complication of rupture. It's a surgical indication, and lack of collateral blood flow is a risk factor for it. So when you have these mechanical complications that I've outlined here, which one of them has the worst prognosis? So most folks got this answer correct. So of all of these complications, the one that carries the highest mortality rate is ventricular septal rupture. Which of the following statements is untrue? Mortality with ventricular septal rupture exceeds 75%. It is always a late complication following an acute myocardial infarction. Rates of ventricular septal rupture have declined with primary angioplasty. Ventricular septal rupture can occur in any infarct distribution, anterior and inferior. Good. So ventricular septal rupture can be a late as well as early complication after an acute myocardial infarction. Okay? The reason why this is important is in most textbooks, ventricular septal rupture usually occurs on day 4 or day 5 after an acute myocardial infarction. In the real world, ventricular septal rupture can occur as early as day 1 following an acute myocardial infarction. Mortality exceeds 75%. The likelihood of ventricular septal rupture is directly proportional to your ability to open up the artery. So primary PCI is better than fibrinolytic therapy. So it decreases the rates of ventricular septal rupture. It can occur both in an anterior as well as an inferior distribution. So in the exam, nearly all the time, you have a patient who comes in with an acute myocardial infarction who either receives primary PCI or fibrinolytic therapy. The patient is usually doing well, and then you are called back to the patient's bedside because something bad has gone wrong. Either there's pulmonary edema, there's recurrent ST elevation, there's shortness of breath, or there's electrical instability. And then when you come back as the internist or the consultant, you have to figure out, is this a ventricular septal rupture? Is this reocclusion of the vessel and reinfarction needing emergent angiography? Or is this a mitral valve rupture? And the things that will go in your favor are there will be an exam, so clearly they will mention a murmur, the location of the murmur. They may give you a swan tracing and show you a CV wave on the swan tracing for mitral regurgitation. They may give you an oximetry and give you the oxygen saturations in the right atrium and right ventricle, showing a step up of oxygen saturation of about 5% between the RA and RV. They may give you an echo and say there is new fluid around the heart which looks hemorrhagic, having to suspect rupture. So one of these clues will be there, and based on what that clue is, you've got to make a decision which one of these you're going to deal with. But you can take a bet there's going to be at least 2 of these complications are going to appear one way or the other in the exam. So these are the mortality rates in the setting of shock with all of these complications. You can see that ventricular septal rupture, by and large, has the highest complication rate, up to 80%. So in the exam, if you have a ventricular septal rupture in a very stable patient, normal heart rate, blood pressure all right, no heart failure, the question is, what do you want to do with this patient? Refer for emergent surgery. Your friendly surgeon may not want to operate, but you want to refer this patient for emergent surgery because once they go into cardiogenic shock, they almost certainly die. So if you see ventricular septal rupture, the answer is surgery. You may want to put an intra-aortic balloon pump. If you give you a choice of intravenous nitroprusside for medical stabilization, that may also be a correct answer. So how does intravenous nitroprusside act in the setting of a ventricular septal rupture? You have a left ventricle. Normally, it ejects blood into the aorta. Now you have a hole in the ventricular septum. So the left ventricle can either eject blood into the aorta, or it can eject blood through the defect into the right ventricle. So you use intravenous nitroprusside, which is a pure arteriolar vasodilator. As a result, the SVR in the systemic artery falls. So blood preferentially goes through the aortic valve into the aorta as compared to through the defect into the right ventricle. So you effectively decrease the shunt. And so nipride can be a medical option in the setting of you transferring the patient to another center for surgery. This is data showing you how the impact of rupture with the ability to open up the artery. So clearly, here's streptokinase. Here's streptokinase plus TPA. This is TPA, and this is primary PCI. We know that primary PCI is the most effective strategy in terms of opening up the artery. Streptokinase is the least effective. So as you go from a least effective to a most effective strategy, your likelihood of the complication of rupture decreases significantly. In terms of timing, this is data from the shock trial. The median time from MI to ventricular septal rupture was about 16 hours. So if somebody has this complication on the first or second day after their myocardial infarction, don't straight away think, oh, this cannot be ventricular septal rupture because it's not classic day 4 or day 5 presentation. It's a very, very early complication. And the reason why you get an early complication is that ventricular septal rupture is mainly of 3 types. You can get ventricular septal rupture very early on in somebody who's had a very small myocardial infarction. Okay? So the infarction is small. There's a small area of the heart muscle that doesn't move. The rest of the heart muscle is compensating and moving briskly, and so this causes a shear and one segment tears off against the other. And that's what happens on day 1. The remaining kinds of infarcts are the ones that are reported in the literature, which the ventricle myocardium thins out and you get a leak as a result of that. And so this is just an example of what I was saying. This is a type 1 rupture that you can see on day 1. This is a picture of the left ventricle. You can see the anterior septum is moving, the posterior wall is moving, the motion is hyperkinetic, very hyperdynamic LV function. So when you take a look at this, on an EKG, there's a small inferior MI, the question on the exam should be, this person should not be in shock because of what I'm seeing on the EKG or what I'm examining, and in this case, what I'm looking at on the echocardiogram. The right ventricular function is normal, there is no mitral regurgitation, there is no aortic regurgitation, and then you see this image, you can see a cleft form here, this segment is completely normal, this is a small area of infarction, and when you put color, you see a big hole in between. So that's a type 1 ventricular septal rupture in the setting of an acute infarction. Okay. So what about mitral regurgitation in the setting of an acute MI? So which of the following statements are true about papillary muscle rupture? The anterolateral papillary muscle is most vulnerable because it is involved in anterior myocardial infarction. The posterior medial papillary muscle is most vulnerable because its blood supply is from the PDA, that's the patent. The vulnerability of the papillary muscle is determined by the coronary circulation, and the anatomy of the papillary muscle determines vulnerability to rupture. There's only one true statement. Okay, so the thing to remember is that the anterolateral papillary muscle has dual blood supply. Okay, so very rarely do you get papillary muscle rupture in the setting of an anterior wall myocardial infarction. So again, in those clues that you get in the exam, if it's an anterior wall myocardial infarction, at least on the internal medicine exam, it's highly unlikely to be mitral regurgitation. If you hear a murmur there, it's more likely a ventricular septal defect. If it's an inferior wall myocardial infarction, you have a choice between a ventricular septal rupture and a papillary muscle rupture. let's move on with that. So acute severe mitral regurgitation, complicating acute myocardial infarction, extremely high mortality rate, okay? If you medical treatment, you can survive, but the survival is really poor. So again, if you have a patient in whom the integrity of the mitral valve is compromised in the setting of an acute myocardial infarction, you have the same three choices as ventricular septal rupture. You can stabilize the patient by putting an intra-aortic balloon pump. You can stabilize the patient by using intravenous nitroprusside, and you've got to refer the patient for surgery. And these are the three options that you will get. And I think these questions are, especially with having more hospitalists and having more critical care roles in internal medicine, these questions are more and more prevalent on the exam because you may be the only person at night taking care of these patients. It's important in all of these questions to read the story that's up front. So the kind of the poster child for someone who's going to get one of these complications will be an elderly female, first myocardial infarction, hypertension, single vessel disease. So they're going to set up an elderly female, first heart attack, who's a little hypertensive and has a small infarct, and then has this catastrophic complication and is in trouble. The other thing that comes in the exam is cardiac rupture. And so nearly all the time with cardiac rupture, it will be someone who's had a myocardial infarction where you are called back to see the patient. The patient is usually nauseous. They'll get some Zofran or something like that, which happens all the time. They'll get an EKG, and the EKG will show some early signs of pericarditis because blood has just leaked into the pericardium and irritated the pericardial space. So if you have a story of recurrent chest pain in the setting of an acute myocardial infarction with a lot of nausea and vomiting, diffuse symptoms, restlessness, agitation, think about rupture, because they play this against, standard delirium in the ICU. All of these complications can take place, and so you may do something really wrong, which is what they want to do in this setting. So they certainly want you to pay attention to this in the setting of an exam. And so think about rupture in a post-infarction situation with nausea, vomiting, and restlessness, especially in an elderly person. With acute papillary muscle rupture, 33% of folks die immediately, 50% within 24 hours, 6% live longer than 2 months. And so there is an urgency in taking them to the operating room, no matter how stable they look. And so they should go to the OR right away. And so we'll end with just some of the guideline stuff that we spoke about. So if you have acute papillary muscle rupture, class 1 indication for emergent surgery. Free wall rupture, again, class 1 indication for urgent surgery. And patients with STEMI complicated by ventricular septal rupture should be managed for urgent cardiac surgical repair unless further support is considered futile. Okay? So this has nothing to do with hemodynamic instability. If you have a ventricular septal rupture, no matter how good you look, refer them for an operation. With that, we'll end this session.